but especially the rodents. Mpox is endemic, right? So it will actually then move from the rodents to human. It can also move to domestic animals. We don't know for now, but those are the things we want to understand. But the monkeys that got infected with Mpox or monkeypox are not the reservoirs. The monkeys just got infected like humans. The virus was actually observed in monkeys, and hence the word monkeypox. But the reservoir, the discovery, I think 1970, 67 or 78, but observed beyond the usual geographical areas. And once it got out, it started spreading through respiratory droplets. It started spreading through contaminated fomites. It started spreading through very close contact. It also started spreading through sexual transmission. What we are not sure yet was the vertical transmission. And once it reached there, the variant changed. And then now we have the crisis in human, and that is the human-to-human transmission. The crisis was first observed, human-to-human transmission, among men who have sex with men around Spain and Europe. And that's when it was actually declared an emergency, a public emergency of concern. So realize the history. Mpox has been around, colleagues, for a long time. But once it got into human, and now we started human-to-human transmission, that's when the problem was observed on a global scale. And that is because the virus started adopted to human, and then now the human-to-human transmission has now become well established. And then if you just go back to the virology, to understand really what is going on, the family name is Mpox viridae. The genus is actually the orthopox, the one in yellow, molluscum contagiosum virus, you all know. And then the family of the viruses that are of interest for us now is the orthopox, where you have the vaccinia virus, where you have the variola virus, the monkeypox virus. Now we are calling it Mpox, cowpox virus. The variola virus is a virus that was responsible for smallpox, which has now been eradicated. But you can actually see the multiplicity of viruses you find within this family. And these viruses, all of them, have a propensity to move from animal to human. So we still have quite an array of viruses, Mpox viridae just being one of them. And then when we move closer to how the virus actually replicates, Mpox or orthopox viruses are actually among the largest viruses, huge viruses, DNA viruses, enveloped. Once they access entry into the cells that are infectable, the DNA is released into the cytosol. And this DNA does not even need to move to the nucleus for it to be able to be translated to messenger RNA, and then to go through translation into the various proteins, and then move to the aspect of morphogenesis, the viral assembly, and then eventually to begin to actually bud out of the cell. I say this because there are two areas here: the release of the DNA and the late transcription, and the area here around viral assembly, the morphogenesis and viral assembly, where two drugs have actually been targeted. And there are actually two available drugs, or three available drugs now, antiviral drugs, that can be used for treatment of Mpox or for treatment of orthopox viruses in general. So this mechanism has been known, for a long time. And this has been because of the early discovery of virus, the early work that was done on elimination of Mpox through vaccine development, so that it's actually very, very clear of how these viruses are replicated. This virus does not reach the nucleus. This virus does not integrate into the nucleus. And once somebody actually is cured of it, there is no chronicity. So this is not a virus that actually establishes chronicity like herpes or hepatitis B. All right? And then the Mpox lineage, very interesting. All right? Clades. It's clade 1, and then clade 1A, and then clade 1B. And then there's clade 2, and then clade 2A, B. When you see this multiplicity of clades, you realize that we are up for some difficulties. And this multiplicity of clades is brought about by replication errors. During these stages of replication, late translation, issues of, especially when you're getting mRNA from DNA to mRNA, there are some errors that are appreciated. These errors are the ones that bring about these variants. But also, upon infection, the human immune system also induces a lot of pressure. So that pressure knocks out quite a number of weak viruses. So the viral fitness allows only those viruses that are fit to move on and replicate. So it is that aspect that actually brings about these lineages. And these lineages may differ in ability to be transmitted. They may also differ in the ability to cause disease. We are beginning now to understand from DRC Congo that clade 1 might be more transmissible. Clade 2 might be more transmissible, and clade 1 might actually be more severe in terms of prognosis. So this is now where we stand, but it just keeps telling you that the evolution is going to continue as more and more humans actually get infected. And just a little bit more on the Mpox lineage, where you are looking at animal reservoir, zoonotic transmission, human-to-human transmission, virulence, and the whole issue of virulence to animals. So you can actually see that clade 1 is mainly the reservoir. That's where it all started, animal reservoir. And then now clade 2 has come in. And then you're actually seeing that clade 2B is now the one that is well established in human-to-human transmission. All right? So it is here that we are now beginning to actually put up research to really understand the various modalities of transmission between human to human. So this virus, they'll keep seeding the human because the animal reservoir is there, the endemic regions are there. We shall keep getting clade 1s in human, but we shall also continue getting clade 2 transmission in human, generating more human-to-human clades. And that's where now the problem has now become completely a human problem. And then just to go back, colleagues, and ask ourselves, how was smallpox eradicated? The smallpox virus is a variole. It was a very good candidate for eradication because one variola had a very narrow host range. No carriers, no chronicity. There were no animal reservoirs for variola as opposed to Mpox. And then there was a highly effective freeze-dried vaccine was available, the MVA. And then the surveillance was straightforward, and WHO created a program to eradicate this. So if you look at these colleagues, and this is a question again I want to put across, this is exactly a similar epidemiology to measles. Measles has a very narrow host range, and the host is human. There are no carriers in measles. There are no animals. There is an effective vaccine available. Why have we not eradicated measles? And I'd like at the end somebody to give me a sense, because this is indeed, colleagues, a discussion. Semi-effective vaccine, why haven't we not eradicated measles? Polio could be slightly different because there's an element of the environment that comes in. But I want us to speak to polio as we look at the totality of what I'm saying, that we must put all these things in context. And then the pathogenesis is clear. Usually the infection is through contact, and we come into virus excreted from the purulent lesions. The lesions are usually on the face, on the genital. It can be very generalized or very specific. Through that contact, the virus is actually picked through the skin or through the mucosal membranes. And there's usually the first local replication is in the mucosal surfaces and through maybe pregages in the skin. Usually the immune cells, the dendritic follicular cells, the virus is then picked by the lymphatic circulation, and it ends up in the lymph nodes. Now you get the secondary replication stage. And then from the lymphatics, the virus is then released into the peripheral circulation. You get a mild viremia, which then begins to give you a rash. You then get very extensive viremia, which gives you a generalized. And during that viremia, the virus is actually seeded, a lot of it into the skin, the mucosal surfaces, the respiratory tract, and into the genital area. There is very extensive replication, and the virus settles there, and very, very quickly, the virus actually disappears from the peripheral circulation. So you'll find this virus maybe in the liver, in the spleen, but there's no element of chronicity. Once you heal, you actually heal completely. And then there's now, in terms of human to human, there's a potential of aerosol transmission, infected person coughing and a potential host, looking at aerosols and droplets. So again, this is telling us that those of us in crowded environments, matatus, the hospital settings, where maybe somebody is still very early infection, but they are already in early viremia, where maybe the lesions have not occurred, the potential of transmission through respiratory tract is actually possible. So we are now beginning to talk about risk. Who is at risk? If you had the vaccine, who would you vaccinate? In terms of just understanding the dynamics of what we have actually gone through. And then sometimes it's life-threatening. The mortality it ranges between 1 to 10%. Most often than not, monkeypox or Mpox is self-limiting. People cure completely, and we believe those who are cured develop an immunity. As I've said, it has been endemic in West and Central Africa for a long time. I've told you rodents. And then down here is now the spread, respiratory, secretions, skin to skin contact with body fluids from the vesicles that we found on the skin and the pustules, and then fomites, colleagues, shared towels, contaminated beddings, and all these things. So when you hear fomites, shared beddings, contaminated this then calls into question the hospitality industry and the low-class hotels that some of us find ourselves in. That becomes a critical issue. And that's why I told you the totality of risk, who is at risk, and the totality of surveillance, and where do you do your surveillance, comes in very, very critically, and the social and the sexual contact. So with this picture, colleagues, we must then now be generating a sense of who is at risk. If a vaccine was available now, and you only had maybe 100 or 150,000 doses in Kenya, who would you give with this understanding in mind? And that is a discussion we must have. All right? And then the clinical symptomatology, we've gone through the pathogenesis, is usually a skin rash or an exanthema. And this exanthema might be generalized or very specific in certain areas. And then the lesions are very variant in development. You might some that are already in the form of a pustule and some that are just beginning. And the rash is actually scattered. So the differentials here are things like rubella and things like measles, and maybe chickenpox. But then you go beyond, and the most interesting things is also to find anogenital region, or actually a rash on the lips, on the face, or even in the oral cavity. And also, one thing that is usually very peculiar about Mpox, that it can actually give you a rash on the palms themselves. All right? So in the human aspect of it, because of what we are seeing through sexual contact, there might be an erectopy. So examining is very critical. And the prodromal symptoms can be very mild. Could just a flu or fever, but usually look entirely. Look for fever, look for a lymphadenopathy, and then look for other co-infections with sexually transmitted infections. Because the crisis that started in Europe actually started in men who have sex with men. And then these are just examples of some of the lesions that you'll actually be able to see, either isolated or multiple, and you can actually see lesions on the palm and in different sizes. These lesions are actually sites of viral replication. During viremic stage, this virus on the skin, replication. So this is really what we should actually looking for. And you see these raised pustules. Inside is a fluid, and within that fluid, you can actually find what? Replicating virus, and the inflammation you see is actually the immune system trying to respond to bring the virus under. And these are the penile lesions that will look like. And I'd like to bring out here and now that you cannot use condoms as a safe way to stop one from getting infected with Mpox or monkeypox. Because I've heard people talk of safe sex. As far as Mpox is concerned, and from the position I stand myself, I'd like somebody else to correct me. There is no use of safe sex to actually stop getting infected with Mpox. So these lesions might confuse you with herpes, when they crust and form ulcers, they might confuse you with a chancroid or molluscum. So please examine, take a very good history, and this is how actually the lesions actually look like. Some might actually be pinpointed, some might actually confuse this for herpes. So take time to really examine so that it is very clear that you have taken a good history, you know the risks involved, and you can actually take samples and ensure that somebody with suspected smallpox does not get away. All right? And then the diagnosis. Samples for diagnosis. You need swabs and you need fluids from the skin lesions. You need oropharyngeal swabs because the virus could actually also be within the respiratory tract. You need rectal swabs, you need genital swabs, and there's an element of urine. Ideally, collect multiple samples and preferably use a viral transport media to store these samples before you quickly ship them to the lab. And we need them in the lab as quickly as possible, but take them to the lab in a cool box. If there are any delays, store these samples at -20. Blood is not used for diagnosis. Blood cannot be used for detection of Mpox because the viremic stage is actually very brief. So if you collect blood, the only thing the lab can do is detection of antibodies to actually look for IgM or look for IgG. So my push here is that pick samples from actual lesions themselves. Get these samples to the lab. There are very good PCR reagents available in this country in various labs where a diagnosis can actually be made. And then from PCR, we can go further to sequence so that we also type and get to know what kind of clade we are actually dealing. And diagnosis, we have actually gone through this, all right? Okay, so blood is actually just mainly immunology, but really we need the exact samples to go through the RT. Same thing we were actually doing with SARS-CoV-2. And the infrastructure for SARS-CoV-2 is still available. So all that you actually need are reagents. So we should not be having any problems making a diagnosis of Mpox. All right? And then the countermeasures, colleagues, vaccines, treatment, and non-pharmaceutical intervention. But for me, the third one, surveillance and public engagement, is key. We want to ensure that we are in the right places. The communities that are involved are aware. We are aware of the risk groups. We have the countermeasures in terms of information that we require. And then treatment. Not available across the board, but antiviral drugs are available. And then thirdly, vaccines. And I can tell you here and now, there won't be enough vaccine doses to go around globally. So what will happen and what we must do as a country is to clearly demarcate what our risk groups are. So that if we get 100,000 doses, who is at the highest risk, that should be the first person to actually be given these vaccines. So these really are the countermeasures. But the surveillance and the public engagement is key so that we actually stop this virus from being transmitted. And then the rest of the others can actually follow. Because once you begin to treat, then it means the infections are all over the place. The train has already left the station. And that's what we'd actually done. And then in terms of treatment, I told you that we have two sets. We have two drugs. One drug works at the DNA, viral DNA replication. Those are the two drugs that are in red. And the other drug works at viral assembly, where the immature virion is coming in to connect with the Golgi apparatus to give it the right morphology and coat it properly for the virus to be able to bud out. So antiviral agents are available, but we only want to reach there and have them available for the few cases who will actually get infected, and for the few cases who will actually need this particular treatment. And then thirdly, the vaccines. The one they are calling Joinas, I can't even pronounce it very well, the modified Vaccinia Ankara Bavaria Nordic, is actually an attenuated, non-replicating orthopox. It is actually a virus that was designed from Vaccinia. This is a, and you realize within the orthopox we have Vaccinia, we have variola, we have cowpox, and we have the monkeypox. So this is a generalized, modified Vaccinia that is capable for actually inducing an immune response against variola, smallpox, and against monkey. This is a vaccine that was used for of smallpox. It is available, but not in adequate doses to go around the world. So indicated for smallpox as well as monkeypox, but adults above the age of 18. Okay? Not for pediatrics, not in pregnant women, and licensed by FDA in 2019. So this vaccine is available, but it's not available in adequate doses because the stockpiling is in actually limited doses. And then you have the ACAM. This is a live replicating vaccinia virus. This is mainly licensed in the US. Again, not for use in pregnant women because of the fact that is a replicating vaccinia vaccine, right? And then is indicated for active immune against those who are determined to be at risk. So this vaccine, you can also use it as a post-exposure. So MVA can be used as a pre-exposure and also as a post-exposure. And post-exposure is that once there's an identified case within a household and you identify the contacts, those contacts are presumed exposed. And since they are presumed exposed, if they are within 14 days of exposure, then we can actually administer these vaccines post-exposure, right? And then just various aspects, because issues of adverse events following immunization, things took a toll on some of us just trying to explain the safety of COVID vaccines. These vaccines have been around for a while. So because of their replicating competent, risks do exist, all right? And these risks are actually known. So in this country, when we begin to administer, we shall be aware of cardiac adverse events. For example, if we have ACAM, okay? We shall be aware of administration. And the ACAM 2000 is actually given by a bifurcated needle, and you give it with a sclarification, as opposed to MVA, which is actually given as subcutaneous. So we will look at this very, very clearly so that we understand exactly any major problems as we go ahead. But usually these vaccines, from what we have heard from DRC Congo, they usually elicit a very robust immune response. People might present with fever, pain at the site of inoculation. Some might actually have some aspects of lymphadenopathy, but eventually these are side effects that actually clear and the individual becomes actually immunized against infection. And then vaccination and immunization will actually require a very coordinated approach. All right? We will require collaborative surveillance. And we actually need to identify specific risks, and especially individuals or communities or groups who are at risk. And then the whole aspect of ensuring that we empower communities to actually also adopt protective measures. Vaccines, to tell you the truth, are not going to be enough. Okay? So all this we must bring into account. Achieve control of Mpox outbreak with focus groups at risk. Who is at risk? We must still advance research to understand how to communicate, who to communicate to. How are people going to access these countermeasures in terms of information? What do we do with the auxiliary aspects of it, like hotel industry, where people spend nights and where there could be contamination from mites? How do we minimize zoonotic transmission of Mpox? Because I've told you endemicity is still there in DRC Congo. And we don't know, as it gets more into human, we don't know whether this virus can actually begin to move into other domesticated animals. So the goal is actually to stop Mpox outbreaks in the African region. So we have a tall order, colleagues. And then vaccination is only going to be recommended for persons at risk of exposure to Mpox. So our issue now is to begin to sit together as communities to identify population at risk of exposure. And then to put in place in readiness pre-exposure prophylaxis with 1 or 2 doses, and then post-exposure vaccination for those who have come into contact or those who have been traced to be related to a confirmed case. So these are the things that we must be discussing. These are the things we must actually be putting in place, right? More or less the same thing that we went through during COVID. But the interesting aspect here is that these vaccines can be both for pre-exposure as well as for post-exposure. And then just the various products, the MVA, 18 years and above, the LC16, the Japanese product, use of bifurcated needle, free single dose, ACAM, single dose, 16 years and above, right? And then the orthopox and the others. But the two, the MVA and the L16, are actually very critical. And I think the L16 can actually also be used in the pediatric. But for pregnant mothers, we still don't know yet. And then just the safety profile of the various categories we are actually talking about. So I will not go into these, but if there is need to really interrogate these vaccines at a closer look, we can always get into this discussion with another Zoom. And then just to give guys a sense of the modified vaccinia Ankara, because this is the vaccine that has been used the most. and realized that it was and came into use in the 1970s, right? It traces its heritage to the 1950s. So that when people begin to ask, how come there's a vaccine now? MVA is not new. And I always ask colleagues, where were you in 1950? Where were you in 1950? MVA